Hi, and very welcome to our Patient Safety Week. And we're proud and very thrilled to have some very excellent guests today. It's Mirkka, Secretary General of the European Patient Safety Foundation, and also the CEO of the largest, I would say, association of patients organizations in the world. It's IAPO and Kawaldip Sehmi. And we are, as FOKUS Patient, affiliated members of the European Patient Safety Foundations, and we're proud about that because there are very few organizations in Europe and in the world who are really focusing on this topic, the patient safety. And I would like you to start, Mirkka, to tell us a bit about your organizations.
So first of all, thank you, Penilla, for inviting me to take part in this Patient Safety Week. I'm very sorry that I couldn't follow the other discussions because, my Swedish is rather limited. I still remember a few words from my time when I was traveling to Sweden, but they are not really helpful for for healthcare topic. So, and we are, of course, the foundation is very proud to have FOKUS Patient as the affiliate member, because having patients in it's very difficult actually to have the real patient on board on the foundation and or body that wants to bring different types of stakeholders, because reaching real problems of individual patients, we are all possibly a patient, but to reach the groups of patients, it's very important but very difficult at the same time. So I was very, very happy. We were all very happy when the FOKUS Patient became one of our first affiliate members. So I would like to introduce a little bit the work of the Patient Safety Foundation. So shall I do the presentation now? I will try to share the screen. So to explain a little bit more about the work of the foundation. So let's try if it works. Up. Okay. Desktop. We try. Just a second, because it seems that I need to allow. Okay, just a second. Okay. Oh, I need to reopen the Zoom, so I'm sorry for this. It's the first time I'm doing the presentation, so I will have to reconnect probably.
You put the green button in the end of the screen. Yeah.
Okay,
share.
Now it should. Okay.
Yes. Very good.
Okay.
Thank you.
Okay, good. Up, and we will try with like this. Does it work? Is it okay?
Hi there.
Very good.
Okay, perfect. So, as said, thank you very much again for this invitation. And in my presentation, I would like to introduce a little bit the work of the foundation, then to point out the importance of each of the levels, the local, regional, national, international, and the world level in patient safety improvement, and also the importance of the cooperation between the patient groups and the healthcare worker groups. So I will not, because when I was asked to bring this topic a little bit and develop it, you can see it also from the point of view of patient being in a hospital, for example, and how the two at the exact situation, how the two can cooperate to make the outcome safer. But I will develop the situation where we have the groups and representatives of patient and healthcare professionals cooperating together. So the European Patient Safety Foundation is a independent and public interest foundation, and it constitutes a neutral knowledge and best practices exchange platform and it promotes the innovative, meaningful, but mainly sustainable and replicable solution for patient safety improvement, because we understand the importance of accelerating the patient safety improvement, and that's only possible if we take into the account, or if we try to bring the solutions to as many levels as possible, to replicable solutions. So the foundation is multi-speciality oriented. It understands the importance and specificity of differences in culture and functioning of healthcare system in different European countries. It supports and works very closely with local and national patient safety bodies, and it recognizes the importance and the role of human factor in patient safety improvement, and it's based on the strong, constant, and open dialogue between different patient safety stakeholders. I will explain a little bit about the history of the foundation, because it will help you understand that despite of the fact that we were launched in 2000, or the foundation exists since 2013, we are at the very beginning of our work. So it has been founded by European Society of Anesthesiology in 2013, and very soon different scientific societies and also industry joined the foundation, and two main projects were launched, and that one of them was Kid Save Life project that was promoting the resuscitation, the cardiopulmonary resuscitation by bystanders, and especially promoting, teaching this CPR, basic CPR already at school for children as of age of 12. Because in many countries, maybe, I don't know about Sweden, but in Denmark, it is part of the education, but it's certainly not the case in many other European countries. And then second project was the Opus campaign that was it's called Optimizing Patient Undergoing Surgery. And that was a collection of recommendation that would improve the outcome of the surgery if these recommendations are applied before, during, and after surgery. So then after, between the year 2016 and 18, there was a little gap, and it was mainly due to lack of the professional back office management of the foundation. And then as soon as Dr. Stender took over, and we start to work on the new strategy and relaunch of the foundation. We spent a lot of time thinking hard and brainstorming how to bring the foundation to the existing system of all the stakeholders. And then there was the COVID-19 pandemic that caused the delay of our work. And finally, at the beginning of this year, we were able to start the collaboration with our affiliates. So the foundation is working with 3 different types of affiliate membership. One is individual, then there is non-for-profit and industry affiliation. And we try to have different representatives of different stakeholders of the system. And I'm very happy that, as said, that FOKUS Patient is our non-for-profit affiliate member who is representing patients. Then we have the platform for continuous improvement of quality care and patient safety that is working on patient safety and quality improvement in Belgium, especially, well, in the Brussels and Wallonian region. Then we have the patient safety database that is an open and anonymous incident reporting system focused on non-technical skills. So that's this database was launched and is managed by Dr. Frédéric Martin and Dr. François Joulin from France, and they collect these incidents and that are then analyzed and shared through the quarterly newsletter in French and in English. And we have individual member is Dr. Johannes Wacker from Switzerland, who is the consultant anesthesiologist from Zurich, Switzerland, and also associate lecturer on patient safety at the University of Zurich. And our industry representative, that's Fresenius Kabi. So despite a very small number of affiliates, we with together with our board members and affiliate members, and also our informal contacts, we start to cover quite a lot of European countries. So we start to we try to be in touch with our different representatives and to follow the work in the field of patient safety in different European countries. The strategic axis of the foundation, they have been fixed on 3 different strategic axes, and those are the people empowerment. And for the time being, we focus mainly on the healthcare worker empowerment, and we deal with the topics as leadership, teamwork, well-being, burnout prevention, fatigue. And then we focus very much on the second one, multidisciplinary cooperation. And I would like to develop a little bit more about the importance of different levels of the, I called it vertical cooperation. Well, there must be more sophisticated word for this, but I think it was quite easy to explain. So I think the local and regional level, I found it the most important level in the patient safety improvement, because those are the levels making the real change and real impact for the patient. Is the nurse in the hospital, is the healthcare professional or clinician, or is the family member that will speak up, that will raise the concern. It's where the change and the important tasks are being done. And then we have the national level, or regional and national level, that should provide the frame to support this work on the local and regional. It depends on the levels of the country, so that's why I had the problem to fix this regional level somewhere. So it depends really how the country is organized. And then we have the international level, which I think it's very important and well, extremely important for the acceleration of the improvement, because there are many different initiatives and projects and research and I don't know, collaboration that are already existing, but we need to share this information and work together so that we don't reinvent the wheel in each country again and again, just because most of the time there is this language barrier. And then we have the world level that is directs the strategy, the long-term vision and the long-term goals. So like the WHO Global Patient Safety Action Plan that's now being that was commented by the different stakeholders, and it will fix or provide strategic direction for all stakeholders for the next 10 years. So that's the vertical cooperation. But then we have this patient and healthcare professional group cooperation. So we have this patient who has, and we know all those numbers, so he has a very high chance that something will go wrong, because we have 4 out of 10 patients are harmed in primary and ambulatory settings, and up to 80% of this harm can be avoided. So we all have, there are many studies and numbers proving the danger actually or the level of preventable harm. But then on the other hand, we have the healthcare professional who, according to the Institute for Healthcare Improvement, so it's the recent study, says that we have more or less 60% of physicians who are considering leaving the practice. We have more than 70% of physicians who know at least one colleague who already left the practice through to poor morale. We have 33% of the new registered nurses who will start seeking a job within 1 year. And then as they explain it, it's burnout is at epidemic proportion. So we have both, we have this, there are big problems on both sides. And it is obvious that the patient, he wants to have safe outcome of the care, and but he has very high chance that something will go wrong. Wrong identification, poor communication, medication errors, problems during or after surgery, the infection. And then the healthcare provider, except of very rare occasion, he wants to deliver the safe care. And he's most of the time he's even personally responsible if something goes wrong with the patient. So he has very high interest of delivering safe care, but the system makes it difficult, and it can be due to time pressure, it can be due to stress, fatigue, burnout, or loss of autonomy, administrative burden, or simply a culture in a hospital. So they both have the common goal, which is patient safety, but they both have also a common problem, which is the healthcare system. So from my point of view, and the cooperation is extremely important between these two groups, because it's not the question about what needs to be done. There is already enough of scientific research, enough of tools and white papers and call for actions for patient safety improvement from the side of the healthcare professionals, so they know what needs to be done. But the question is how to make it happen. And that's why these big groups need to cooperate, patient and healthcare professional scientists, scientific societies, to make sure that the strategy is developed and make this change happen. It will happen quicker. So because it will happen bit by bit, we will get there, but maybe we should accelerate it a little bit, and cooperating together, defining the best strategy would make the change come quicker. So that was what I wanted to say. Thank you very much. And I'll be happy to reply to any questions, and also by email if someone would like to contact me.
Thank you so much, Mirkka. And I do believe we have some questions after we also have heard Kawaldip's presentation and the interesting work both in Europe and in the world. You had a great pyramid there, Mirkka. So it's just approaching to Kawaldip area work here. So please, Kawaldip, very welcome.
Thank you very much, Penilla. I think it's very nice to be with you, and I think Sweden and your patient's commitment to patient safety is really refreshing. The reason why I'm coming here, as I've spoken to Penilla, is that Sweden has two great roles at the world stage. One is that it has really pushed the agenda of gender and human rights, number one. And the second was Sweden has really participated in health system reforms, and especially in improving healthcare in low and middle income countries through the Swedish aid organizations, the government's commitments, your parliamentary, and also, as I was explaining to Penilla, that compared with all societies, you find the Swedish populations are more civil society oriented. You know, every household is a member of something or the other, and that civil society engagement, the Swedish citizens, you know, doctors, teachers, and even individual families, you know, the way they play roles into volunteering and improving things is amazing. So I'm so glad to be here on that respect. So we are coming from a global perspective, and we're saying that we have seen that in 2 years ago, if I'd gone somewhere and said we would like to look at the patient safety system of, say, Swaziland, or even look at maybe Peru, the health minister would have said, go out, none of your business, health is a sovereign matter. Now it's different. I think they have seen that a small town in China could have such a huge impact on them, that health is a global matter. And therefore we must bring back that opinions that were there, that it's through global solidarity and national unity that we have to transform things. The second part I want to talk about is that why did the WHO's Global Patient Safety Action Plan 2021-2030 first come about? The first reason for it to come about, and now what it's turned into. The first reason was simple, that the amount of suffering and the amount of heartache and the amount of loss of life, mobility, and income was unsustainable. It was already, as we said, it was a public health problem, the dimension of it. our healthcare was unsafe. There was a loss of trust in them. People were actually viewing, in many low and middle income countries, people were actually viewing the health facilities as dangerous as crossing a road. You know, you could be hit. Anyway, you're taking 50-50 chance, as bad as that. I'm not talking about Swedish driving, I'm talking driving in Cairo. So you can imagine that health professionals were actually looked upon as if they're taxi drivers, you know, can't care, can't less, and will kill us, you know. And that system needed to be reformed. Now with the pandemic, that has totally changed again. Now we have now seeing our health facilities really where you get infections. You know, we are not only killing the patients, we're also killing the health professionals. So suddenly our health systems are unsafe, even to a larger degree that we had previously thought of. And that we thought we all had the perfect health systems, and we found out we didn't. So now the Global Action Plan has become different. IAPO, I've put all the links in the chat if you look at that, so it's easier for you to peruse them, download them, copy them over to your systems, and then you can look at them. We first set up the IAPO's Patients for Patient Safety Observatory. This is in the middle of a pandemic. You can imagine how stressed we were about this. We said this can't go on for long. So the IAPO Patients for Patient Safety Observatory is based now in Geneva. We'll be getting a WHO collaborative status with soon. And our hope is to bring the patient researchers. You know, there are patients who experience this, our doctors, lawyers, scientists, social scientists, and they've got insight into the statistics. And they're also patients who are what I call the pathfinders. These are patients who really, because of their conditions, know every corner of the health system, you know, even to the point they can actually point to a surgeon, you know, I know where the ventilation machine is, or I know where this equipment is because I've been coming to this hospital for so often, you know, so I can point you out. And in fact, I was laughing at one patient from Namibia who was saying that, you know, part of my role is to show the consultants who come to visit us where the departments are located. You know, this is how our role is. So we're bringing those along. We're saying that the observatory will take that out. If you are looking at patient co-created health systems, we must have the science first. We must have the patient experience first. We must have the patient perspective guiding that. We do trust scientists, but I think they do develop what I call blind spots, and sometimes they miss out things. It's like the proverb of 5 blind men trying to identify or describe an elephant. You find each of them will have a different angle of the elephant and will describe it differently. So same way with the safety problem, you'll have the same thing. Thirdly, we are also engaged with the Jeremy Hunt, who is now heading he's the health minister and now secretary, foreign secretary. He started the global movement, the global ministerial patient safety summit. And I was telling Penilla, I'll be inviting her to there through Jeremy. And that's very important. We are trying to get commitment from the top down because we think bottom up can work up to a point, but we need top down. Unfortunately, because of this whole pandemic situation, that ministerial summit was canceled, but we will review that again. So we're trying to get that into it. And now, at the same time, we are looking at making patient safety a big issue this year at the World Patient Safety Day on 17th September. Again, I put some notes there. Please do look at them when the thing happens. But if I can revert back to what the problems we face are from what the WHO had said to us way back. And I'll just share something with you and then we can start from there. Can you see that?
Yes.
Yes, okay. So we know what the Director General had said in his report. So just to make sure you know it's that report there. Okay. In his report, he had said that the several issues we can look at. And I think medication errors are very important, and they're still happening. I think right now there are lots of things going on. And in biosimilars, I think please have a look at that particular field. Biosimilars are presenting us great difficulties. Yeah. In vaccinations, again, we've started the same problem, medication errors. We don't know what's going on, doses and etc. But the biggest one that has really taken us is healthcare associated infections. We're looking at this that from what happened with COVID, but we're also looking at our AMR action plan, and IAPO has also set up an AMR alliance of patients to look at this. We are saying if the infection doesn't happen in the first place, then there is no point in developing an AMR resistance. Let's make sure that infection doesn't happen. Hospitals are clean. We still got unsafe surgical procedures going on. We still got that nobody's following. Some of the people are not following that checklist. Unsafe injection practices are still there. We saw now with the COVID-19 vaccination program, they're risen up quite seriously, because I think we're talking about single use, very important to do that. And then one of the places we're really working in developing patient literacy. I think diagnostic errors, I can say, if I say 100% is upon the health system, that'd be correct. But then if you looked at it, it's actually shared down, whether it's a human error or diagnostic equipment error. And lastly, I think it's a health professional and patient responsibility. I mean, patients should learn to speak up. You know, the surgeon is touching your right leg, and when it should be your left leg that should be seen at, when they need to speak up and be more assertive. People from our genetic disorders are still continuing with unsafe transfusion practice. It's amazing how they still keeps going on. So sickle cell and thalassemias in low and middle income countries are very important. Radiation errors, I think where oncology is now present, we're actually saying some of this could be reduced through immunotherapy. So there are solutions available now, which genomics could reduce the need for radiation, aggressive radiation. We have got Carl Conrad on the Sepsis Alliance. He's spoken quite vociferously. We have a Sepsis Alliance. And then lastly, venous and thrombosis, and then unsafe mental health. Mental health still is got a problem, I think, and that will rise. Now, to then to share the other component that we're trying to look at. One second, let me get that up. So that was the Global Action Plan for 2021. This is put into a resolution, and I think we should all share to that common vision. So we're committed to that, and that no one, zero harm. So we are approaching that zero harm, and it is achievable if we put our shoulders and thoughts into it. We then say that it is an action from governments, health facilities and services, and stakeholders, including the WHO. So it's depending upon us, it's our responsibility. We know the mission is quite simple as well. We need evidence-based actions, you know. We must have science. And to this, I must tell you that what alarmed us in the recent days is that sometimes there are far too many academics speaking to far too many politicians, and on vaccine safety, they've made a complete mess of it. We are changing our tack on this slightly. We're saying that we should have some trained experts people can go to, people who are sensitive, and we don't have the mess we have had. It's in the African language, there's an animal on the savannah called the wildebeest. They say this animal has been designed by a committee. This is what has happened now. Our vaccine safety policy in Europe as well is like almost designed by a committee. The way the European Medicines Agency was left aside, it was terrible. You know, it was really embarrassing for the world. We know the goals are clear. But then comes the section we really worked hard on, that we must bring the patients, families as partners, and we look at the collaboration. And this is where our Patients for Patient Safety Observatory has come into place, that we must bring them into it. And then we must look at the evidence and the policy instruments that are feasible. The two must be. I mean, it's pointless having a lockdown when half your population is not accepting it. Please make sure that these policy instruments are first discussed and are proportionally designed, and their acceptance is. People will know why you're doing what you're doing, and it's not magic that's going on. And lastly, I think we must mesh these 6 things out of it, 6 at the further bottom, 3, 7 at the top. And the key area is that in the center is really about patient and family engagement in the process. And we must look at the health informatics, very important to that. And that, I think, would help us bring everything together. And lastly, please do join us on the World Patient Safety Day. And also, please join us on our African Patients Congress, which is happening in July. I want the student to be there to comment on this, because I would love to hear you to step in and advise some of when there is no hope, you provide hope. You know, I think that's something the European patients have always done. And also at our Asia Pacific Congresses. Thank you, Penilla and the guests. Thank you for your time.
Thank you so much, Kawaldip. And it's so interesting to see both of your organizations' perspective and the good work within patient safety. And one question I have immediately is about the legislation within the different countries in the world and in Europe. In Sweden, we have a patient safety law, and it's supposed to be followed by the professionals, of course, in healthcare, and to avoid harm and injuries. But how many countries do have that specific legislation about patient safety? Do you have any idea, Mirkka or Kawaldip?
Yes, there's a study going on through the WHO. I was sitting on that. My background was training in law, and also Patients for Patient Safety Observatory is also looking at. If you said effective law, you know, meaning law that really, you know, de facto and then de jure it's been implemented, then there's a handful of countries. You know, it's only about 20. Yeah, okay. No more than that, in a sense. Elsewhere, but then there are about 40, if you combine, they do have these laws, but they haven't translated them into policies, practice and standards and guidelines. So these laws are in by shape and form only, you know, so 40 in that. And then there's a mixture of others where it's safety is mentioned within something else, you know, which gets complicated. It comes in, your rights are embedded in some others. So effectively, I think to what we said was, they are effectively about, out of the 194 or so country, we do think that 100 or so need are really inadequate, and then out of those, about 50 are severely, you know, severely out. They do need to. So yes, that was where we got the numbers. But please do wait for this study to come through. Yep. But then to hint at this, one of the areas that we have seen WHO is now taking proactive stances is to look at patient charters. And I think that's got a lot more countries. So there you've got about 110 countries now having some form of patient charter. And I think that should be soft law, as I call it, you know, which then combines, like, for instance, in Australia, this soft law becomes part of the consumer. So there you never say it's a patient, you know. There's one way to make an Australian really angry is to say you're a patient organization, a consumer organization, you know. And so taking this as a consumer law. So within consumer law, they're almost applying that, good skill and, the European directive, about the quality of care the workman needs to be done, should apply reasonable skill and duty to this, and the product should be reasonably designed. So they're taking that way through consumer law. But patient charters most definitely, and then these patient charters could then be developed into harder law in areas. Thank you.
Thank you. I turn on to turn to Mirkka, who are representing the European level here, and since FOKUS patients are working from the European patient, I always say the words in the wrong order. European
consumer, it would be easier then.
Yeah, European Charter of Patients' Rights. Sorry,
Yes.
I've been saying these words so many times and still get it wrong. But I mean that's kind of I mean a patient charter who is really a basic level for patient rights, and where two of the bullet points are really focusing on the patient safety. So
But
how do you think we can apply it more in our daily work?
that's where the local level comes to the importance of the local level, because the charter is there, it's available in all European languages, but I don't think it's been promoted in all European countries, and certainly not to the point that every single patient would know that these are my rights and I can use them. And so I definitely think that more promotion and education of patients should be done in Europe. That's certainly the case. I come from Slovakia, and there is still the common practice is that you are a patient and you have no right to question the decision of the doctors, and just you need to follow the rules. So I think there is a lot to be done.
We had a seminar yesterday about standards within healthcare and for patient safety, and it was very interesting because it was a Swedish initiative some years ago who have really resulted into a European standard for patient influence within healthcare. And it was so interesting to hear about the process to get there. And there were questions raised, of course, from the participants. How has it been implemented then? Because it's one thing to produce reports and standards and legislation, but it's always also, as you pointed out, Mirkka, it has to be done. It has really it has to be a meaning for people to be working with all the good things that are said and written. So how do you think, both Kawaldip and Mirkka, do you think standards are too poorly talked about or informed?
I think the standards, I tell you, standards are like red rags to many politicians, especially at European level. I've worked with this, and I tell you, it starts with cream, it's cream, thick cream, thick Swedish milk cream. By the time they get drafted and written across Europe, they're like 0.01% fat milk, they're diluted so much. Each time it goes, it dilutes. In the end, it's very difficult to find where the milk was, what this is. And that's what needs to be now changing. I think the standards is the way to go. If our health devices are made to the same standards, the CE mark, which inspires confidence, our medical equipment, our health facilities, our electrical, everything, the CE mark needs to be there, then it's clearly that medical devices, there is this movement now going on to get that medical device standardized. And clearly we've got the European Medicines Agency there really pushing forward. I think they should now be pushing further inroads with the manufacturers to get those labeling and everything correct. And lastly, I think what we think was within the education and training of professionals. I think currently some of the European bodies, European doctors and dentists and others, nurses, are coming around to it, but the problem is getting the national bodies to change their mindsets. I think that's where the problem is. And very often the national body does not want to accept this. And it's really bad healthcare across Europe because, for instance, I know of cases we're doing on legal every time it comes up. It's a medical practitioner working in, say, Spain. He performs something very negligently. All he does is he resigns his post before the hearing, and he goes back to his home country, wherever it is in Europe. Yeah? And 4 weeks later, he's practicing there. Or there's no censure. We can't do that cross-border. That needs to be looked at. Make sure that the negligence and censure follows cross-border. So we don't have national bodies sort of saying, no, it's ours. So they need to develop that as well. So standards can only work if there is some kind of punitive background to their breaching. So it's not a guideline. It's a standard. It's there to be implemented. So that's, I think, the enforcement part is really bad.
That's what I think as well with not only standards, but in general in project, we often it's the development or specification will stop when we will define the thing. We will define the standard and then we will assume that it will be applied. I think we need to, when developing the project or standard or leading for some change, we really need to think up to the lowest level how to make it happen and to provide the guideline about how to implement it. So this is the responsible part. You need to have, I don't know, hospital management on the board, agreement, and then you have to have this. So for this project, we need to align the longer path, not to stop when defining the project or the standard. Go to the further in the process of defining the goals and what we want to reach.
But I think it was interesting, Kawaldip, that you said if it has been consumer rights or demands from the consumers. Sometimes patients are called clients or customers or something like that, and some people don't like to be called like that. But do you both think that it has been more increased influence within the healthcare systems if people had been seeing patients as consumers and have really, been seeing consumer rights more than? I mean, sometimes people look at patients they are supposed to be the same within a group, but everyone can be a patient, and no matter what kind of background you have or fancy positions or whatever, everyone can be a patient sometimes in life, and it's wrong, I think, to just make them one group all in together, but sometimes patients' rights, I believe, they are overlooked, and because the patient's voice isn't so strong as it should be. Or do I have get it wrong, or what do you think?
No, I mean, I think one of the things we are looking at IAPO, we have been saying is we need patient-centered healthcare, and that healthcare needs to be in line with the human rights-based approaches to healthcare. What we're finding is that if you look at the anthropology of healthcare, it has always maintained its charity roots. If you go back to the charitable hospitals set up way back in 1300s, and health has always seen as a charitable, ending of suffering, and not as a right. It's only in 1945 onwards that you see when the social welfare states, where things are strengthening up. And I think that movement is now, with the pandemic, I was so glad to see at the World Health Assembly that Executive Board, Sweden and plus a few other European members start talking of a new social contract, not only in Europe, but around the world. This new social contract is precisely that. Within that, they are going to review healthcare as a right, as a fundamental component, and not as a charitable thing. It's got to be changed. Our relationship with the government and our health system needs to change. I think that's a big development. Please do follow that development. It's absolutely brilliant, because it's appearing firstly as the new pandemic preparedness treaty, but underneath it, there is this new social contract that they're talking about. Yes, we need to move past that. I think we do still struggle on that it's that right element by a consumer has better rights than I do, as a patient, and that's really wrong. Even if you look at, if I have a dispute with my supplier, Amazon, I mean, it's amazing. Yeah? Amazon deals with over 200, 300 consumer complaints in a day and resolves them by the end of the week. If I put in my complaint as a patient who's received some negligent treatment, I have to go through almost like one whole year before everything gets sorted. That is not right. So we need to maybe look at how patient harm is addressed, consumer harm is addressed. So yes, we do need to look at that. Yeah.
Thank you.
Well, what I think is that even the patient-centered healthcare should go even further. It should be people-centered healthcare, because if you compare, if we think about consumers, then we bring the companies like Amazon or Microsoft, they understood that it's not to be able to satisfy the customer, you need to have the happy workforce. So they invest a lot of money to make for the well-being of their people, to make them align with the purpose, to be motivated, to have very good condition. There will be even functions as happyologists, people who will be checking at their employees if they are fine, if the family, especially now during the pandemic, calling home, is everything fine with your home? So I think if we want to leave to this consumer or people-centered healthcare, and we need to make sure that also we look at the well-being of the healthcare force. We cannot bring or improve the patient safety if we have tired and burnout and unsafe healthcare workforce. So that's why I completely agree, but I would bring it even further to the people-centered healthcare.
It's a combination that is needed, yes.
I think clapping for our health workforce during the start of the pandemic needs to be followed by actually major changes, structural changes, redesign of how their work is carried out and how we engage them and how we look at the mental health and respite. I think they're really burning out so fast. And I think Europe, by the end, I've already noticed this, many of our workforce is now traveling to maybe Saudi Arabia, to other facilities, to Australia, New Zealand. They're just given up on our health systems, and that's bad.
We have a question, and it said that, would you say that even if some states, they are skeptical concerning particular patient safety issues, NGOs may and should play a complementary role?
Yes, very definitely. I think this is where in many European countries, we have got what is called the judicial review mechanism. Yeah, this is mechanism. Some patient, I'm very supportive of those patient. Some of the patient organizations, especially in Latin America, you can see that, you know, they don't touch anything to do with the clinical aspects of things, the guidelines or service provision and that. They have been just set up to look at human rights and patient rights within the context of judicial review. Anything that happens, denial of service, any breach of harm, they don't want to go down the avenue of the, you know, I call it the rat run, you know, trying to get this done from this official, that official. They use the courts, straightforward. The matter is put into court for judicial review, and things start happening quickly. Now that, for that society is okay. But for the European society, where we are looking at NGO based from bottom up, very definitely. Institutional democracies in Europe clearly rely on patient organizations to put things. As you know, from, for instance, thalidomide problems way back in the 70s, 60s, and then asbestos in the 70s, the Volvo, all these car giants really got embroiled in it. And now post-COVID, long COVID will come in. So yes, we do have a role. It is very important for NGOs to pull that complementary role, at least provide the mental health provision, you know, counseling for the patients harmed, provide them with lower services, as I said, holding hands to find social welfare provision for their family, for themselves, rehabilitation, very important. Get them back to work and being independent, and also kind of get the patient around the things. So it's got to be a combination of work, I think, partnership between the state and non-state actors. You can't have one or the other taking precedent. Thank you.
And Mirkka, you have a great work to be done also to reach more of the organizations within Europe, both from the healthcare professionals and from the patient side.
Yeah, and I will do my best to to try to do it. It's not easy. It's I have to say it's not easy because especially because of the situation of the pandemic. You know, you all know that once you go to some kind of a meeting and congress, the contact it's much easier to make contact and to have well, at least informal agreement about future collaboration. So it's not an easy task, but there is a very high interest from the countries to, even if not maybe from all of them, to be officially part of the foundation, but certainly to be in touch and to have the networking channel. So I try to work on both at the same time, to have the official affiliation so that we can really shape the future and we can really work together, because that's the point of having the affiliate members, to discuss common strategy, define the priorities. Okay, so we all think that we should attack this problem first, and we will all try to bring it to our countries, because that's again the national actors, though they know their system and they know where to go. It's not the European Foundation that will be able to make any change in Poland, for example. We need to have the national actors on board to be able to do it. Yes, I hope we will try to have more people on board.
And we are happy to be a member of your organization now, and we FOKUS Patient are hoping to be an affiliate member also of the IAPO soon, so we can spread the word together about not only patient safety, as we have discussed today, but also about patient rights and a lot of other questions within healthcare. Thank you so much for joining us today, and we'll be seeing each other, I hope, at the Patient Safety Day in September.
Yes.
But
Yes,
I would really hope to see you in Sweden at one of our events. You should have been here already in May last year. So we're still waiting.
We look forward to that.
Yes, very much. Yes.
Thank you so much for today.
Just to say, I've got my jab, yeah, so I'm waiting for my second jab, then I can travel.
Okay, that's good. Welcome. And for those who have been joining us today, and also we have been recorded this meeting, and it will be available at our YouTube channel, Focus Patients. So please join us tomorrow again. We're celebrating the Patient Rights Day, and also we are looking forward to the Patient Advocate of the Year. There has been 6 organizations nominated, and it's very exciting to know who is the winner tomorrow. So thank you all for today, and see you again.
Thank you very much. Thank you very much again.
Thank you. Bye.